crusaders. Um, so, during a woman's regular menstrual cycle, what happens is that there is a tissue that builds up and it sheds if she does not become pregnant. This is something which everyone knows. So, women with endometriosis develop this tissue that looks similar to the endometrial tissue outside the uterus. And every month, this misplaced tissue responds to the hormonal changes of the menstrual cycle and it behaves like the endometrium does. It breaks, it bleeds, and it bleeds outside the uterus. This leads to the inflammation, swelling, and scarring of the normal tissue surrounding the endometriosis implants. This is what exactly happens in endometriosis. So, today we are going to be talking about yet another session on endo awareness. Despite being the second most common gynecological condition, this affecting 1 in 10 women, this particular condition takes a massive 7.5 years to get diagnosed. Can you beat that? 7.5 years. So today we have with us Kathleen. Kathleen is is the perfect person to be talking about this, and she's going to be telling us about delay in diagnosis for endometriosis. Just a brief about Kathleen. Kathleen is the former chair of Endometriosis Association of Ireland and works as a medical scientist in an acute hospital. She has volunteered as an advocate for over 22 years. She is a former member of the World Endometriosis Organization's steering committee and current member of the ESHRI Endometriosis Guidelines Review Group. She undertook research into the use of internet for those living with endometriosis and the impact it has on diagnosis and treatment. Kathleen, so nice to have you here with us.
Thanks, Dr. Shilpa. It's lovely to be here, and thank you to both yourself and Dr. Vimy for inviting me.
Vimy, back here for another session. How does it feel?
Yeah, we're back. And yes, a delay in diagnosis of endometriosis is a huge healthcare burden as well. It affects patients psychologically, and the complications of the disease itself cause a lot of problems for the patient, their quality of life, their work life, so social life, everything gets affected. And on an average, as you said, 7.5 years, yes, all the studies which have been done, 7 to 10 years of delay has been noted. And it's a huge delay. And apart from physical, the psychological impact is huge. And the healthcare burdens, yes. Patients go through a lot of mental trauma as well as financial trauma, which they face during this journey of getting a diagnosis. Also, getting a diagnosis is very important. Some of the studies also, where the survey was done, patients said that they feel that once they get the diagnosis, it is therapeutic for them.
True.
They feel that, yes, now I know that I have something. Till the time she was going to the doctors, doing investigations, she was not being diagnosed. Everybody was saying it's all in your head and you're just over exaggerating. It's nothing. It's normal. So this normalization of symptoms and gaslighting and all in your head builds up. And once they get a diagnosis, it's really a relieving factor. So this is all it as therapeutic, really. And today we are going to discuss in detail what are the factors responsible for delay in endometriosis particularly, because there are many gynecological disorders and they can be picked up by clinical examination or by imaging modality. Endometriosis has some factors which are responsible for its delay in diagnosis. True. So we are going to discuss that in detail. First, maybe we can tell Kathleen her journey about endometriosis, how she was diagnosed and
so Kathleen, how long did it take for you to get diagnosed, and how was your journey from the time you started having your period?
Yeah, I started my period when I was 12, and the average delay to diagnosis in Ireland is slightly longer, even than India. It's 9 years. And when I was 12, and that's, let me see, 32 years ago, so I'm giving away my age, nobody had ever mentioned that periods were supposed to be painful or not painful. And I had massively heavy bleeding as well. And, you know, it took about 2 years before I realized that this wasn't right. And I spoke to friends and they didn't really have the same issues. So I spoke to my GP and I didn't really feel that I got a hearing. It was just expected that I was looking to get out of school and looking to get out of household chores and helping at home. And I had read in a medical textbook that we had in the house about primary and secondary dysmenorrhea, and endometriosis was one of those things. And I thought, this sounds like me. This sort of sounds like there could be something there. And I went over and back to my GP multiple times. And like I was told I was too young. You know, I was, you know, no chance that it could be endometriosis because that's only for women who are over 30. And even if it was something like that, you know, don't worry about it until you want to have children. So this battle went on. And as I got a bit older and I started to read a bit more about it, I realized that, you know, this is almost certainly what I had. We have to remember this is the time when we had no internet. And, you know, I was relying on scraps of information I could get out of library books and that. So when I eventually trained, I was in my training year as a scientist, I was able to ask for private appointments at my own cost. And that there was a battle. The GP wasn't happy to refer me. She actually wrote on the letter to say that she didn't think there was anything wrong, that this was just me being me, over dramatic. So when I went into the gynecologist, he was fantastic. I had my big pain diary and I had, you know, all my little notes and everything, and he had a look at it and he was like, oh, you have endometriosis, you know. He says, we'll do your surgery and see how we get on. So about 2 or 3 weeks later, I had my surgery and he came around the curtain and he was like, 2 thumbs up. And it was like, we found it, it's in there. And he drew a little diagram with all the little spots everywhere. Now, unfortunately, at the time, there was no way he could actually remove any of the endometriosis. But as Vimy has said, the relief of having a name for the pain, having somebody believe you, having somebody validate all of that horrible emotion and just everything that had gone on for the years before that, you really felt like you were going crazy at times, where nobody cared. Everybody assumed that you were trying to get out of something, you know. But it's like I would say to a lot of young women now, if you're missing school or college, there's something up. But if you're missing something like a family event, you know, like say like a family wedding or christening or, you know, something like that, that's a real red flag. You know, you don't miss these things willingly. So yeah, it was a struggle. It was 9 years of fighting with people. And I think I lost count of doctors. I think I've probably seen about maybe 9 or 10 different doctors in that time. So yeah, it was tricky.
It's crazy. It's crazy. It took me 25 years to get diagnosed.
Oh, stop. Oh, I don't feel so bad.
So that's how it is. It's more of a mental trauma to go through so much without knowing what you're having. You know,
That's
because
it.
you know you're going through something and the doctors just don't believe you. You know, because your sonography reports come normal,
Yep.
your blood reports come normal,
That's
everything
it.
looks normal, you look healthy.
Yep.
So I think there's a big gap between the diagnosis, the people believing you, and what you are going through. You know,
Absolutely.
and people who don't have it will never understand what a person is going through.
No, no. That's one of the things, isn't it? It's you really have to have walked in the shoes to feel this. It's so hard to describe, and we can, you know, we've lots of people who empathize, which is brilliant, but that level of being pushed down, being ignored, on top of the pain is just something else.
True. So Kathleen, how is it? I mean, obviously I have been through it, but tell our audience, how is it to be living with a condition like endometriosis and adenomyosis?
Yeah, for me, my most major symptom was pain and the heavy bleeding, and that went on for such a long time. I was very fortunate that I was able to travel to the UK to have the Marina IUD fitted, which helped with the heavy bleeding. And unfortunately, they couldn't fit it in my local hospital due to cultural issues and religious issues.
Okay.
So even that extra burden of having to travel was quite difficult at the time. But I always sort of credit it with sort of saving my life. It stopped the bleeding to the point where the anemia was not happening anymore. I wasn't sort of passing out with that level of bleeding. Now, it didn't help the pain, but it allowed me then to sort of try and build myself up a little bit and try and fight the pain. So over the years then, I suppose the symptoms started to pile up as the pain became more progressive. It wasn't just really, restricted to mid-cycle and menstruation itself. It ended up then becoming a lot more chronic, a lot more severe. Pain for me was always right-sided, travels down into my leg. Got the very heavy uterine pain, back pain. And then the usual symptoms that come along with that. So fatigue, bowel symptoms, some of the urinary symptoms as well too. So having to pee in the morning was a dramatic event, having to get back into bed and put heat on to make sure the pain would ease as well. But this went on for, I think up until probably 3 years ago when I had my last surgery. Life was almost unbearable. At times, I was on very, very high doses of different opioids. I'd already had 7 different surgeries and I'd had countless procedures to try and manage this level of pain that I was in. My sleep was gone and my health was just all over the place. My mental health was completely, the same as well too. It was hard to focus and hard to sort of have a life outside of your work or anything else that was going on. And I was very fortunate then. My last surgery, which was 3 years ago, was very successful. So my uterus was removed to take out the adenomyosis, and that solved that issue. And the surgeon also very carefully excised all of the endometriosis that he found. And the dramatic change in my pain pre-surgery and post-surgery was just unbelievable. So much so that I'd actually had to set alarms to take my painkillers. Whereas before I couldn't let them slip. They were always in my hand, or they were in my handbag, or they were very close by. So I do have some chronic pain, but I am so thankful that it is 95% better compared to this time 3 years ago. So it's amazing.
So
really
happy, so happy for you, so happy for you. Trust me. I mean, it might have been like a very, very long journey to recovery from where you started to now. So good. So how many surgeries did you go through, Kathleen?
Yeah, so that would have been my 8th surgery, which is not something I would recommend to anybody, and I know we have this conversation worldwide, the first surgery or one surgery done right, it's so important. And, I stress that to a lot of the women that I speak to in Ireland, that we've got into this culture here, and I'm sure it's the same everywhere, and I see it here, that women are being offered laparoscopies every 2 to 3 years. And you think, well, why is that happening? Is it money? Is it to placate the patient, to quieten them? Because these treatments aren't effective. They're not treating the root cause of the disease. They're leaving disease behind. And often I think women are being fobbed off after a couple of surgeries. Well, look, this hasn't worked for you, so it's back in your head. There's something wrong with you if you didn't recover. Whereas my 8th surgery proved to me, through photographs and through the histology, that all of my disease was still left in place. And you could see the evidence where tissue had been ablated at the top and endometriosis trapped underneath. And a lot of endometriosis that had never, ever been removed. So I think, again, researching your surgeon, finding somebody who will work with you, finding somebody who understands is so important.
Absolutely.
Many of the patients, they do the surgery and come back after 4 months or 5 months that my pain is still there, and our sonologist usually maps all the lesion, and some lesions are still there. So they ask us, "Ki, doctor, is this has come again? It's a recurrence." So basically, there is a difference in recurrence and residual disease.
True.
So most of these endometriosis patients have residual disease.
Residual disease,
The
yeah.
de novo recurrence is very, very rare if the complete excision is done. Yesterday only I had a patient for whom we did surgery 6 months back. So usually after 3 months or 4 months, we do their repeat scan to make out to check any lesions are still there, what we mapped pre-surgery. She came after 6 months because of COVID, and there was no lesion. So I told her, now if you get endometriosis, that I will call as recurrence. So this is residual. There is no specific definition for recurrence of endometriosis until unless there is a standard of care or everybody practices excision surgery.
True.
Or they make sure that they have removed everything.
The problem is also that a lot of people don't know about it.
Yes, they don't know about
No, they don't know. The doctor says a surgery. It's as simple as that. They don't tell the patient it's going to be an ablation or an excision in the first place. So the patient also does not know.
I won't blame them. The doctors also don't know.
That's what I'm saying. It's a lack of knowledge that's there generally.
Medical teaching was like that.
Yeah.
The medical school, they never told us that what endometriosis, how it should be treated. Chocolate cyst only we learned, and never learned about excision. This once we came to practice and we read through the papers and we came across some of the experienced doctors like Dr. David Redwine or Horace Raymond, when they are practicing, it is making a difference. So we started when we came to practice. We were never taught in our medical school.
Absolutely.
So that's the reason they never offer. And I was just mentioning to Kathleen, if we teach the doctors, this is also difficult because they have been taught like that in the medical school. So
there has to be a change right from the medical school curriculum,
And because we have fair randomized controlled trials with evidence, we can't tell every doctor that this should be practiced. But yes, this has shown a very good results. Excision is the gold standard right now. Ablation should not be done. First surgery should be the best one. Yeah. Then we can make a difference to endometriosis patients' lives. Otherwise, it's difficult.
True. Vimi, now that we have, we were talking about adenomyosis, what exactly is the difference between endometriosis and adenomyosis? I mean, if the viewers would probably want to know that, medical terminology.
Many times, but again, for our new viewers, I just brief it. Endometriosis basically is endometrial-like tissue implantation outside the uterus. It can be on the ovaries, peritoneum. It can be anywhere in the body, actually. But most common location is the ovaries, peritoneum, bladder, bowel. These are the adjacent areas in the pelvis where it gets implanted. It makes its own hormones. It is not dependent on the ovarian hormones. That's why the hormonal treatment does not work for endometriotic implants. It causes a lot of scarring, inflammation, and it also causes pressure on the nerves. That's the reason they also have radiating pain and a lot of symptoms. Most common are pelvic pain and infertility, but they have bladder symptoms, bowel symptoms, fatigue, depression. It's a whole body disease, actually, Shilpa. I must say it's a chronic whole body disease. It's not just confined to uterus or ovary. Now, when same kind of tissue starts invading the myometrium, the muscle layer of the uterus, that is called as adenomyosis. The muscle tissue starts growing, it forms a bulk, and it can be diffuse, like completely involving the uterus, that is called as diffuse adenomyosis. It may involve a focal area of the uterus, that is called as focal adenomyosis. So a patient may have endometriosis and adenomyosis together, or only endometriosis or only adenomyosis. Definitely the treatment lines are different for both the disorders. Endometriosis is excision. The treatment, whatever are the lesions have to be removed. For adenomyosis, if you ask me, the treatment is uterus removal, but yes, we tailor the treatment to the patient needs. For a young patient, we can't recommend hysterectomy. We definitely try medical therapy. If it does not work, we change the line of treatment. There is a device called as Mirena or intrauterine device. And finally, last option is the hysterectomy if nothing works out. As last session, we also discussed, Shilpa, that hysterectomy does not cure endometriosis.
That's right.
You remove the disease, not the organ. So wherever it is affecting, you have to remove that. So adenomyosis is in the uterus. That is why the treatment is hysterectomy. But for endometriosis, it is not the treatment. As Kathleen had endometriosis and adenomyosis, both, she was offered hysterectomy as well as excision of the lesions. So do not confuse both of the lesions. Yes, they may coexist and your treatment may be tailored to your needs and your symptoms.
Absolutely. Makes sense. So, Kathleen, how important do you think is it for the patient to get an early diagnosis?
Oh, I think it's very important. I think we see over time, where patients have been left for a number of years, and like yourself, they're up to 25. And I've seen it myself in Ireland, 30 years waiting on a diagnosis. The mental health impact is huge. The societal impact is huge. Women become less, involved in, their family life. They become less involved in their study and work and all of that. But the thing is as well, we don't know enough about endometriosis to say that it's not entirely progressive. So somebody who's diagnosed early, maybe in their teens, and where the disease is removed, the assumption is that we are improving their fertility. There's less chance of damage to the nerve structure and less chance of developing chronic pain. And again, that earlier diagnosis can help stop that cycle of ineffectual treatment. So multiple hormone treatments that again cause issues. They can cause a lot of side effects, or multiple sort of surgeries then again that can sort of delay things. And again, it's cost too. We've got a huge amount of money being paid out into blood tests and imaging, and maybe a lot of other diagnostic processes that are leading away from endometriosis. But I think the earlier we can get women recognizing that symptoms are perhaps not normal, and get them to present to their medical professional, I think the better. I do think the outcomes have potential to change the woman's life completely. I know the literature is quite lacking in terms of what would be, more concrete benefits or definite benefits, but this is because the studies have not been done. It's very, very difficult to find a group of patients who've been diagnosed early, or a large enough group of patients. We all know the people who've had the long delays, but I find it very hard to find women who've had a very short time to diagnosis. I am involved in a research project at the moment where we're looking at a device that'll help guide women and their clinicians towards a shorter diagnosis time. So we're hoping that will, help lead and support the research that's out there already.
I'm truly hopeful. I think there'll be a lot of patients who will have a lot of benefit with what you're actually making. It'll make life simpler for a lot of people, a lot of women like you and me.
Hopefully.
Yeah, I'm sure. So, Vimi, as we just said, that it takes about 6 to 10 years for a woman to get diagnosed with endometriosis. Why is it that difficult to get a diagnosis for endometriosis?
Shilpa, here I would like to share my screen.
Okay.
You can see my screen?
Yes, I can.
So basically, if we look at the major hurdles in endometriosis care, as I said, there is a lack of standard of care. Like fibroid has to be removed, myomectomy we do. But for endometriosis, excision has to be done. Still, it is not standard of care with all the practitioners. Gaslighting by medical fraternity and peers is a very, very common factor. The symptoms are dismissed. Their symptoms are not validated. It's all in the head, and they are told that you're exaggerating. Some families, there is a lack of familial support as well. They don't understand them. Delay in diagnosis, which we will discuss in detail, what are the factors responsible for delay. And in medical school, endometriosis is still not a subspecialty. It should be a subspecialty. It really needs a multi-specialty approach to treat this disease. And there should be a separate training for all the doctors who are being trained in gynecology. Once they finish their gynecology training, they should be trained in endometriosis care. and lack of excision specialists globally. We have handful of surgeons who do excision surgeries. Now, if you look at the different studies, there is a long gap in symptom onset and diagnosis, symptom onset and diagnosis. So this comes to an average of 7 to 10 years of delay. And endometriosis, if we look at the symptoms, there are two main symptoms, the pain and infertility. Pain can be painful periods, painful sex, or chronic pelvic pain, and infertility. These are the two major common symptoms. But I will say that the real pain is much, much bigger. Women with endometriosis experience diminished quality of life. Their work life is disturbed, their family life, social life, everything is disturbed. There is increased incidence of depression among these women. Suicidal tendencies have been noted in women with chronic pain. Adverse effects on intimate relationships because of painful intercourse and chronic pelvic pain, increased incidence of marital discordancy, divorce, all social problems are arising because of this. Limitation on participation in daily activities, reduced social activity. As Kathleen said, if you can't attend a family function, the red flags you have to identify, but until unless you have a diagnosis, you can't even say that what you're going through. Loss of productivity and associated income, and increased risk of chronic disease. And it leads to significant direct cost to the person who is suffering and to the healthcare system as well. Now, if we look at the factors responsible for barriers to endometriosis care, why it gets delayed, there are 4 factors. That is factors related to disease, patient factors, physician-related factors, and organizational factors. If we discuss the disease, there are no real biomarkers or no definitive test to diagnose endometriosis. As Shilpa said, all the tests came normal. She was never diagnosed. There is no marker for endometriosis. There is a marker for the CA125 that is not diagnostic of endometriosis. The levels may be elevated in endometriosis, and it also does not indicate that it is cancerous. Many patients are advised CA125. It is slightly elevated or beyond the normal range, and they get afraid that what has happened to me. There are pitfalls of ultrasound and imaging modalities. We cannot pick up all the lesions. But believe me, if a trained person do ultrasound for endometriosis patients, they can pick up a lot of lesions. Any deep infiltrating endometriosis where the invasion is more than 5 millimeter, they should pick up on ultrasound with a good machine and a good observer. Definitive diagnosis is only by laparoscopy and histology. So that is also one of the drawback of this disease, that only surgery has to be done and then only we get a diagnosis. And there is a poor correlation between disease severity and staging. Now, if you look at these lesions on the right picture, these are very superficial lesions. It's a peritoneal endometriosis. This cannot be picked up on ultrasound. So these patients keep on suffering for years together without having a diagnosis. Ultrasound can pick up endometriosis cyst, deep infiltrating endometriosis, but most of the scan reports which are done outside, what we receive is only a endometriotic cyst. They do not mention the DIE lesions. So if they are trained well, even a sonologist can pick up these DIE lesions, and the complete mapping can be done, whether they are on the ureter or bowel. This helps us in preparing ourselves for the surgery and preparing the patient also for the surgery. Now, if a patient has a deep infiltrating nodule on the bowel, I have to discuss with her. She may need bowel shaving or a discoid excision or segmental resection and anastomosis. These surgeries do carry a lot of morbidity, and there should be a multi-specialty team available to handle those. So these are the things which we are still lacking. In our team, we usually schedule the patient for surgery after a proper scanning and proper counseling. So these are the pitfalls for ultrasound where we can't pick up early lesions. We also have patients where we operate them and they have only peritoneal disease. There is no endometriotic cyst, there is no DI lesions, and they are in severe pain. Those who are lucky to receive the diagnosis of endometriosis, they describe a delay of 4 to 11 years. And I already mentioned that these women felt a sense of relief in receiving the diagnosis, and they said it is therapeutic. Because all these years they were thinking, what's going on with my body? Is it cancer or something which may lead to, like, what should I say? It may be a cause of death as well. They're not sure, and they're not being validated. Nobody is accepting that she's going through something. A 10-year delay from symptoms to diagnosis, with 70% reporting symptoms before age 20. As Kathleen said, her symptoms started at 12 years, and she was told, you are too young to have endometriosis. Endometriosis does not affect women under 30 years of age. So these are the things which should not be told to patients, because what happens is, if it comes from the doctor, they think that it is correct. So this is called as normalization of symptoms, where we tell them pain is normal, it happens. Once you have a child or you become pregnant, it may go away. So these are the myths which are going on for the years together in almost all the societies. So these have to be eradicated actually, so that a better quality of life can be expected for endometriosis patients. Those who have symptoms at a young age have a delay in diagnosis compared with those first symptoms having at an older age. And I think Shilpa and Kathleen will agree with me.
Completely.
If anyone has the symptoms after 30 years of age, their diagnosis is a little faster, rather as compared to the adolescent girl presenting with pelvic pain. Now, there is also a mismatch between the staging of the disease and the symptoms. You may have a stage 1 or a stage 2 disease, but your symptoms may be very, very severe. So any of the staging method does not correlate with the symptom severity. Now, this RASRM staging we have, it predicts the fertility outcomes. It does not mention anything about the depth of lesions involved. It does not represent the whole spectrum of the disease, and extrapelvic disease has not been considered in this kind of staging. So these are the pitfalls of the disease, but we have a new NZN classification published recently, and it's a very good system where surgical staging can be done involving all the factors. It also includes the peritoneal disease, the extrapelvic disease. So at least there can be a standardization of care, like when I operated, what was the stage of the disease, or if that patient needs another surgery, what stage she is on laparoscopy. So there is a huge mismatch in symptoms and staging of the disease. If we come to the patient-centered causes, patients don't come out and say all the time all these symptoms and talk about it much because of the embarrassment. They have been tolerating it for years, and they have been told that this is normal. And once a gynecologist tells them it is normal, they believe them, because a gynecologist has told that they have validated, yes, this is normal, and every girl goes through it. There is a lot of stigma around talking about periods. Taboos are there. This is a hush hush topic, so they don't want to talk about it much. And they are not certain what is normal and what is abnormal. So I must tell all our viewers, if you have cramps, you take normal analgesics, it comes down, you can carry on your routine activities, that is normal. But if anything where you cannot do your routine activities, your quality of life is hampered, you skip your school, you skip your work, analgesics are not working for your pain, you're using hot water bags, definitely it is not normal. And it has to be addressed, and it could be endometriosis. So patient causes mostly are arising because of the physician-led causes actually. Because if we don't tell them that it is normal, rather than we listen to them and validate their symptoms, it will help them more. The physician causes are, there's an endless list. The medical school teaching, as I already mentioned, that there is no endometriosis subspecialty and it is not being taught. There should be a change in the teaching patterns. Also, if they can incorporate in the schools, as Kathleen said, she had read somewhere about painful periods and not painful periods. So in the school only, when they talk about menstruation, they should talk about painful periods also, rather than in the post-graduation. Normalization of symptoms, I already mentioned about it, telling them that it is normal. Painful periods are normal. For an adolescent girl, if you tell her that it is normal, you can understand a teenage girl, what psychological impact it will have on her life. She starts thinking all her classmates can handle this pain. I'm the only one who can't handle it. So there is something wrong with me. So this should not happen. Misdiagnosis, gaslighting, reliance on inadequate diagnostic test. CA125 is not a marker. Negative ultrasound or negative imaging does not mean patient does not have endometriosis. Reluctance to advise surgery. Some of the doctors say, you wait till you get married, you wait till you become pregnant. Why there is so much of reluctance? Why there is so much of inertia to offer a surgery? If we talk about the Indian population, definitely the families are involved and they really don't want to get their daughters operated on ovaries and anything related to uterus and ovary. It's a huge drawback, and we are trying to counsel our patients that this is not correct and it leads to huge damage to her organs. So that reluctance is from the doctor's side as well. They don't want to advise. So that should not happen. They are heavily dependent on medical therapy. We as excision surgeon believe that all medical therapies are pharma driven, and they really do not, they might reduce your symptoms, but they will not remove the disease. So this will not go away if you take medicines. And the clinical guidelines, they do not provide consistent approach at all. Misdiagnosis, as I said, many of these patients are diagnosed with 2/3 of women are misdiagnosed actually. Half of them have already met 5 to 6 doctors. As Kathleen said, she met 10 doctors. Shilpa already met so many doctors, and that's really true.
And I think I had most of the diagnosis in this.
Yeah, all of these you had, right? PCOS, IBS, fatigue, period pain, normal, depression, stress, anxiety, everything they'll be diagnosed other than endometriosis.
True.
Patients sometimes describe taking a grand round of a specialist. They keep sending them to different doctors. The GP sends to gynecologist says it's nothing, it's normal, get married, have your baby, it will be fine. She keeps going to endocrinologist because they say you have PCOS. They have body pains, joint pains, so rheumatologist is a must. Neurophysician because they have radiating pain. Orthopedician because bone pain. And IBS is the most common symptom, and gastroenterologist has to be there. So all these specialties, they are doing rounds. So a gynecologist can only solve their problem. We are the one who has to guide other specialties. So when we operate on an endometriosis patients, we are always there, even if she has a thoracic endometriosis or a diaphragmatic endometriosis. So they don't identify the lesions. It is the gynecologist who has to identify. So if we can identify and excise those lesions. Yesterday only I had a case. She had subdiaphragmatic lesions on either side of the falciform, and we were not aware of it. So thanks to our team, we had everyone there. And because we could identify the lesions, we excised at the same sitting. Otherwise, that patient would have landed with shoulder pain and other symptoms maybe after some time. Gaslighting, it's very prevalent. It is basically manipulating someone by psychological means into doubting their own sanity. So this is what is gaslighting, and endometriosis. It's very, very common. I think every other patient is gaslighted. It sounds like, why you are so defensive, you are so sensitive, it's all in your head, you are overreacting, you need help, you're pathetic, you can't bear this. I never said that, that never happened. So many things they're being told. Coming to the last but not the least is the most important factor, which is responsible, because if you have to teach all the doctors, organizations are the one which can help us. We as individuals can't reach to all the practitioners. So organizational factors, there is a considerable void in clinical guidelines to direct clinicians regarding appropriate investigation and appropriate modality and the treatment. There is a diversity in symptoms. Some patients may have only fatigue as a symptom. They may not have any pelvic pain. But yes, that suspicion to diagnose should be there. Existing recommendation advocate delay in surgery. There are some of the guidelines which say if your chocolate cyst or endometrioma is less than 3 centimeter, wait for the women to complete her fertility or the family, then you go for the surgery. How it is justified? The surgical treatment or any treatment in endometriosis has to be tailored to patient needs. If patient is in pain, what it has to do with her pregnancies? We are not treating patient as an individual. That is the problem which is creating this gap in care. We are treating them as having an endometriosis, or she has to become or bear a child. So that is, I feel that is secondary. First, we have to look at her symptoms. If she has pain, even the cyst is less than 3 centimeter, or if she has a single peritoneal lesion, that has to be removed. Yes, we are lacking in randomized controlled trials, which can give us some evidence-based guidelines. And existing recommendations are too confusing for general practitioners. They don't give them standard protocols, or they don't give them. Still, ablation is mentioned in all the guidelines and all the textbooks. So if that can be changed, then only we will have a huge change in the standard of care. Until unless that is done, it's a long road ahead. And guidelines, as I already said, that there is a lot of gaps in the guidelines, what they recommend and what they, even medical therapy, GnRH therapy, they say you give the GnRH therapy, if her symptoms sometimes subsides, you diagnose her as endometriosis. So these are the things which need change. I think I was clear in the factors.
Absolutely. Absolutely. Um, so more than anything else, the perspective has to change. The physicians, the sonologists have to see. They, as we always say, your eyes see what your mind wants to see. Till the time you don't really want to see an endometriosis there, you will never ever see it. And it affects 1 in 10 women, which is like a big number. I mean, high time that these changes are brought into picture. So, Kathleen, how did you get into advocating about endometriosis? How did you become an advocate? What does it take to become an advocate?
When I finally got my formal diagnosis, I got in contact with both the Irish and the UK organisations, and I really wanted to make sure that nobody else was going to go through this, and with the hope that at least if I could save one woman, that long delay to diagnosis or the battle to get people to understand and listen to her, that it would be a help. So I was very fortunate. The UK had a helpline at the time, and I was able to volunteer on that. That was where we give a lot of information based on our own experience, but also quite factual information based on the different treatments available. And you would have taken phone calls from not just patients themselves, but their families, their employers, and friends as well too. So it was a great service, and I believe it still runs at the moment. I then became involved with the Irish organisation and took over as chairperson. And I found that even at the very beginning, there was a reluctance to talk publicly about endometriosis, which I completely understood. But for me, it's something I never had any shyness about, and I would talk about endometriosis to anybody. And I think my catchphrase was always, talk about endometriosis at least once every day. So that helped. I think the fact that you can chat about it and quite open. But I think you, as an advocate, I think your first role is accurate information. And we're very fortunate. We have some very, very good sources now on the internet who are being, very, very kind with their experience and their knowledge. And like Dr. Femi there as well, leading by example. She's using excision, she's using evidence-based medicine, and that makes a huge difference. We know we can trust that information. So I can refer to something that she's done, like this talk, and say, look, this is a good source of information. And that's something that the internet has been fantastic for. It's really, really helped open up the whole advocacy side, but it's also very dangerous in the side that there's a lot of misinformation. So maybe we're perpetuating the old myths. We're saying, you know, pregnancy is still an issue, pregnancy is still a cure, hysterectomy is still a cure, where, you know, you have to make sure that you're choosing your sources very wisely. One of the things I think I always recommend is that if you have a strong advocate in your country, or if you have a strong group or an organization within your country, support them. The recent study that I had done had shown that women have a lot of trust in official organizations or strong figures, you know, who speak out on behalf of women. And again, that can be surgeons or it can be patient advocates. But it can be a difficult journey, there's no doubt about it. But with every media article or with every time you share your story or you get chatting to women, it makes a huge difference. And I've often got messages back from somebody I haven't heard from in a long time to say that they're now living and, you know, a pain-free life. They've had children. Their life has been totally changed by our interaction. And even on a day when it's been very difficult to keep going, that just, it's brilliant. You know, it just makes such a difference to know that you've helped. It really does.
I'm sure I can imagine that. Oh, it's such an amazing job that you're doing. Trust me, it is like a it's like a big support for women with endometriosis, because what they need at the end of the day is somebody who understands them and somebody who can support them, who can guide them what needs to be done and what doesn't need to be done. That's how it is. So Mimi, the next thing, okay, fine. The diagnosis gets delayed. Understandable. But what can the complications be?
Shilpa, I'm sharing my screen again. So one is persistence of symptoms. Patient keeps suffering. Nobody is believing her. It leads to.
Mimi, your voice is like very low right now.
Can you hear me?
A little better, yeah.
So in cases of delayed diagnosis, the symptoms are persisting. Patient doesn't have a diagnosis, and it leads to a vicious circle of psychological, physical, social, all the impacts, and huge financial burden as well. Her quality of life, endometriosis patients' quality of life goes haywire. They can't spend quality time with the family, with their children, with the spouse, and they can't give their best at work as well. There is a gap in patient physician relationship. Patients stop believing their doctors because whenever they go and tell them that they have some issue, they don't believe them, they don't validate them, and they say that it's normal. And so there is a huge gap, or we are ourselves creating a gap between the physician and patient relationship. There is a development of central sensitization. Now, central sensitization is a phenomena where once the patient's symptoms, especially of pain, they are dismissed, they become their threshold becomes very, very low. So they may have pain at any site of the body, and with a very, very low threshold, their reaction to pain will be different. They react differently to all the situations. So these are the common things which can happen, which are hugely ignored. Now, what can be seen is the progression of disease, which may cause adhesions, interfere with fertility potential, and organ damage. This we fear because what happens is somebody has an endometrioma or a chocolate cyst. Even if she does not have pain and her diagnosis is delayed, she might lose her ovarian reserve. The fertility is compromised. She may not be able to conceive because her ovarian reserve may be very, very low, or the quality of eggs may be very less. So, and progression of the disease can lead to damage of the organs. Like somebody has a ureteric endometriosis, it can cause ureteric obstruction, leading to renal damage as well. Intestinal obstruction, it may be subacute or acute. Because it's a chronic disease, it keeps on growing. It might invade the lumen of the bowel and they may get obstructive symptoms. These are the most common ones which I'm describing. Can you hear me? So these are the most common ones.
Yeah,
These
can
are the
hear you.
most common complications which I'm describing. But the first four which I mentioned, they make more impact on the patient's life. What I am talking about is more of surgical and clinical based. So both happen simultaneously, and it leads them nowhere. If somebody has a renal damage or a complete obstruction of the bowel, you can imagine with what trauma they'll go through. They also have low ovarian reserves with delayed diagnosis. They may need donor eggs. They may have to go through IVF. So if we address this disease early and in a best possible way, we can improve their quality of life. We can give them a good ovarian reserve, or there's some hope in the later future that they can conceive as well. So delay in diagnosis has a huge impact on their lives, and there has to be a full stop where we can remove these gaps where we are lacking, or again, I'm coming to that standard of care should be there, which we can serve to these endometriosis patients.
Makes sense. So, what can a healthcare professional do to reduce the suffering of these women?
One is we need to change the focus. We have to change the focus from lesion to the patient. The care has to be patient centric. Endometriosis patient care has to be the surgery or the treatment, anything has to be tailored to their needs. It's not one size does not fit all, we say, for endometriosis. Shifting focus from individualized care to multidisciplinary specialized care for endometriosis. I am a gynecologist, endometriosis is my domain, I will handle it, but we don't want any surprises during surgery.
True.
You have a chocolate cyst, but you might have a bowel endometriosis. As I said, we just dealt with a diaphragmatic endometriosis. We should be prepared for that. We should not leave the patient in lurches and tell her that you might need another surgery because we didn't have the specialized care that time. We didn't have a cardiothoracic surgeon that time. We didn't have a urologist available. So that multidisciplinary specialized care is very important for endometriosis patients. And as we always say, it's a whole body disease. It should be addressed like that. And it should be treated by multidisciplinary team where a gynecologist should lead the team because they can identify the lesions and they understand endometriosis better.
True.
Listening to the patient is very, very important to avoid the delays. When they say there is pain, believe them, listen to them, and evaluate them properly. So, if we look at the data, it is a fact that after asking patients to express their concerns, physicians were able to listen to patient story for a median of 18 to 23 seconds and they interrupt. So, no, it's true, Shilpa. Then,
That's a fact. Yeah, I
and
know.
these endometriosis patients, they come with 6 to 7 files from different doctors, and I just let them speak. Just they keep talking that I went this time, I had 6 months back this happened, 1 year back this happened. We don't interrupt. She just, and after half an hour she takes a sigh. Oh, this is the first time somebody listened to me. This is the expression we get, and half of their problems get sorted out. Believe me. So listening to patient is very, very important. Careful analysis of chronic pelvic pain symptom characteristic is useful in the diagnosis and therapeutic management. More emphasis on research and RCTs, randomized controlled trials, and there should be change in the guidelines. So if these changes are incorporated, definitely we can bring in a change because endometriosis is a multi-organ disease. Primary care physician and gynecologists need to fully appreciate the non-gynec manifestation of this disease. There can be just IBS symptoms, nothing else, but it can be endometriosis. Eliminate the fundamental misconceptions and gaps in knowledge regarding the disease. Get the right information. Care providers must consider limitations of imaging modalities before dismissing the patient's symptoms. Patient said, I have symptoms. but your ultrasounds are negative, MRI is negative, so nothing is there. So that dismissing the symptoms should not happen, and avoid normalizing the symptoms. Do not tell your patients that pain is normal. Painful periods are not normal. We have been telling everyone, we have been telling adolescent girls. So, mild cramps, pain is okay, but any debilitating pain which interferes with your routine activities is not normal. If all of us can adopt this approach, I think we'll be good to go to manage our endometriosis patients, where we have a multi-specialty team and there are patient advocates, patients are being guided, and there is a continuous training and teaching. So this is how endometriosis care should be. Then we can bring in the change. And I'm really thankful to my team. They are incredible. I serve endometriosis patients because they are at my back. Without them, it's very difficult to handle endo patients, and they don't get the adequate care if we don't have a multi-specialty team.
True. That's so lovely. I mean, I really hope that patients get enough care and early diagnosis. Kathleen, my next question is, so what steps do you think will bring a change in the attitude in general towards endo patients?
I think we can see from Vimi's slides there, there's a huge amount of work and the medical side. There's also a societal change that needs to happen. I think education at a very young age is very important. We need to get it across to young women and to young boys as well when at school that this particular type of pain is not normal, or these symptoms may warrant further investigation. We also need to let families know that, that there could be a cause for this. This is not necessarily, somebody wanting to skip school or to avoid chores or whatever it is. So there's a societal education, there's an individual education and a medical education. I think all three probably need to happen together. But I think the start of that and where we can start, I suppose, as women living with the condition is that, we can take charge. We can see ourselves as head of the healthcare team. We can become good self-managers. We can make sure that when we go to appointments, with our doctors, that we have our summary of our symptoms or summary of our treatments, have all of that ready. Go in with your list of questions prepared, go in with any research that you have done and make sure that it's from a reliable source. You can always then as well to speak to different advocates and different groups about a particular treatment that you might be investigating. So I think there's a lot we can do for ourselves as individuals, and this also has a knock-on effect for other women as well. So the next patient that doctor will see, he might be able to carry some of our strength and our information forward to the next patient. And I think that's very important. I think, it's a very, very long journey, and endometriosis is not a new disease. It's been around for probably as long as we have ourselves. But we have to find new ways to manage it. We have to find new ways to bring that education to people. And there's so many different ways of doing that. We need to use all of our strengths. And I think working together globally between clinicians, patients, educators, family groups, societal groups, I think that's the way forward for it.
Absolutely. So what I also feel that having the right diagnosis at the right time actually enables the women to receive correct treatment, saving women from so many years of constant pain, and it also helps them to actually live a quality life, stay in work, stay in a social, a good social condition, and also make choices about their fertility issues, informed choices. If they're diagnosed with something like endometriosis and they think that it is something which will affect their fertility, since endometriosis does increase the risk of infertility. So I think early diagnosis would be very helpful, generally. So any parting words for our viewers, Kathleen?
I would just to thank everybody for tuning in, and I hope it's been helpful. And I think the one piece of advice I always give to everybody is to remember that you are the head of the healthcare team. You make the decisions, you hire, you employ, you bring in the specialties. And we tend to focus a lot on the excision on the medical side, but there are lots of other things as well too. Maintaining your social friendships, your family links, trying to continue on with things that you enjoy doing. And we know that that's very difficult when you're in pain, especially when you're in that period where you're fighting for a diagnosis. It's very, very hard. But then look and see where you can get your support from. If you can have a good advocate online that can help you prepare for an appointment, or if you can have a family member that will come with you and maybe support you during that appointment as well too. There's strength in numbers. And I think, there's 200 million women living with endometriosis worldwide. And remember, they're all behind you when you're at that appointment. They're wanting you to get your diagnosis, your best treatment, so that you can just fulfill your life and, again, hopefully then help the next generation of women coming behind us.
Absolutely. Amen to that. We will be able to do that, hopefully. And I think we have a couple of questions before we end the session. So with me, Dr. Girija Shankar Mohanty asks, ma'am, what's the strategy to prevent recurrent surgeries? And also, what's the key point that directs an endometriosis patient to gynecologist, not to other specialists?
That's a good question. So for recurrence, we already mentioned that excision has to be done completely. So we can reduce recurrence substantially, and we can give a patient good disease-free interval. So first surgery has to be the best one, get it done right. And if it is not excision, then there may be a residual disease which patient might come to you with recurrence. Now, the second question, why patient comes to gynecologist is because they have painful periods. They have chronic pelvic pain. And the second major issue is fertility. That is why they come to gynecologist. But they have other symptoms. It is us who has to probe them, ask them about the other symptoms. Sometimes patient cannot identify. When endometriosis patients come, they mostly tell us that they have pain. But when we start asking them, then they come out with IBS, they come out with fatigue, they have all those symptoms, but they are not able to realize that it is happening because of endometriosis. So if you have complete knowledge of endometriosis, you are going to ask all these questions to your patients, that what others associated symptoms she has. Some of the patients will come on their own if they're educated enough and they understand their body well and they have read about it, they can make out that this is because of endometriosis. But there is a set of population where we have to ask them these associated symptoms and we have to come to a diagnosis.
Makes sense. Inayat asks, how long can a woman have endometriosis without knowing?
Without knowing. So endometriosis, as I said, there is no correlation between symptom and the disease severity. There is a percentage of patients where they don't have any symptoms at all. And when they are looking for fertility or pregnancy, they come for the first checkup and they may have a stage 4 endometriosis as well. So this is a set of patients where the symptoms are not prominent and they do not have pain or any other symptoms, but they have endometriosis. So these patients, it may go undiagnosed till they visit the doctor. But what we are discussing, delay in diagnosis, is these patients do have symptoms and they are visiting the doctors and they're not being diagnosed. Sure. There is a difference in the presentation of the patients where delay in diagnosis, or it may go undiagnosed in some cases as well.
Perfect. Hope you were able to answer to the questions which were there. In case you have any other doubts, anyone has any doubts, any questions, you can put it on the comment section. We will get back with the answers. So thank you, Kathleen, for being with us. It was like a pleasure having you over, and it was extremely informative. And Vimi, thanks again. It's always like a pleasure hosting a show with you.
Thank you, Kathleen. Thank you so much for joining us. And Shilpa, you're the best moderator we have.
Thank you.
It's great. Thank you both. A fantastic session. And again, hats off to Shilpa. You've herded us up nicely.
Thanks, Kathleen. And thanks to all our viewers. Thanks for being with us. And thanks to everyone who's going to catch us later. Thank you and have a lovely evening ahead. Bye-bye. Take care.